Getting started with introductions, we would like to share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your Zoom screen. Audio participants, please dial *6 to mute and *6 to unmute. Prior to speaking during this clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot see who is speaking. I'm Jasmine, the registered nurse at Neighborhood Health Centers in Lehigh Valley for the Center of Excellence. We can go around and start with introductions. How about with Bill in the top left-hand corner? Oh, unmuted.
Sorry, Bill, you're muted. Hang on. Okay, now you're unmuted. Go.
Now I'm good. Okay. Good afternoon. Bill Rowan, Director of Lehigh Valley Hospital Schuylkill Counseling Center up here in Pottsville, Pennsylvania.
Thanks, Bill. How about top right-hand corner, Lynn?
Hi. All right, you're on.
There you are. Lynn Wilson. I am a family physician and geriatrician with Lehigh Valley Health Network.
Welcome. Victoria?
Hi, everyone. Victoria Chavez here. I am an account representative at the Echo Institute in Albuquerque, New Mexico, and I am happy to be joining you today and observing.
All the way from New Mexico. Yay! We like your background.
Yeah.
Thank you.
How about Rob?
Hi, everyone. I'm an advisor with the Health Resources and Services Administration's HRSA's Office of Regional Operations. I'm here from Philadelphia.
Awesome. Judy?
I'm manager with the Lehigh Valley Hospital with the GREP program, the geriatric program.
Thank you. And Luz? Can you hear us, Luz?
Yes, I'm a community health worker with the WEC program.
Hi. And then C. Bray? Courtney. There you go. Thanks. Courtney?
It's Courtney Bray from Lehigh County Drug and Alcohol.
Welcome, Courtney. I think we're done out in the Zoom.
What that phone number is?
I think that's Courtney.
Oh, okay.
Yeah.
Okay. All right, I'm Jillian Beecham with Lehigh Valley Health Network, and I do MEP Training.
Hi, everyone. My name is Yamelisa Taveras. I'm the Project Director of Counseling Solutions of the Lehigh Valley, and I provide drug and alcohol counseling.
Hi, I don't think Dr. Javier is visible. My name is Mackenzie. I'm a medical student and soon to be resident with LVHN.
Yay! And I'm Abby Letcher. I'm a family doctor at the Neighborhood Health Centers and one of the clinicians for the substance use program. Yeah, okay. Hi. We have to get we'll bring the camera up. Let's start with any announcements or celebrations anybody has while I continue to log in here. Anybody have anything they want to share about what's going on in the universe of our programs and partnerships?
Well, we had a big motivational interviewing workshop. We were really happy to have people there from throughout the community, from all different folks who work with patients with substance use disorder. So hopefully we will continue to get a little bit of funding and do something like that annually. I'll probably be picking everyone's brains for what might be interesting: trauma-informed care, motivational interviewing, expert, what some of the tools are that we could keep working on. So
Great. And I heard it was a great workshop and you had good attendance.
yeah, it went really well. Great. Yeah.
Cool. Any other news or celebrations? All right. So, today we're talking about the nurse care model with our own nurse, Jasmine. Yay! Yay!
So, opioid addiction treatment, and that's all. Effective team-based care for opioid use disorder with focus on nurse-led model and care coordination and addressing social determinants of health. You have nothing to disclose, Colleen or myself. Okay, so the DATA Data 2000 was an amendment to the Controlled Substance Act and allowed providers to prescribe medications to manage opioid dependence in an office setting. So it's a Schedule 3, for Schedule 3 FDA meds, and then methadone did not qualify for that. And then prior to October of 2002, no medication existed for that. We're going to talk about a couple of articles. The first one, so the Archives of Internal Medicine, Collaborative Care of Opioid Addicted Patients in Primary Care Using Buprenorphine. It was a 5-year experience, and the BMC Boston Medical Center, Boston Medical Center implemented a collaborative model to facilitate expansion of medication-assisted treatment in primary care practices. So we'll be discussing that. So for the office-based addiction treatment model, the OBAT model, OBAT and OBOT are going to be used interchangeably throughout the presentation. So it's office-based addiction treatment or office-based outpatient treatment. So you'll see that back and forth throughout the presentation. The collaborative care model was a nurse care manager model. It was developed by the Boston Medical Center. So it had nurse care managers or NCMs work with physicians to deliver outpatient addiction treatment with buprenorphine and injectable naltrexone. So, and then it's also called the Massachusetts model, if you've ever heard of it. So the model started with the approval of buprenorphine in 2003. So from 2003 to 2010, 425 patients were seen with an average of 3 to 6 admissions per week. And over time, 9 physicians became waivered, and they had 1 medical director, 3 addiction certified physicians, and the most practices were part-time with providers. Typically, on average, they were having about 3 sessions a week. They had 1 nurse, and that grew over time to 3 full-time nurses. They had a medical assistant, a program coordinator, and a program director that spent some time on the project as well. So July of 2016, there were 7 admissions a week with 17 waiver physicians, and 12 were certified. So you can see there was an increase in the amount of prescribers. And then for the amount of registered nurses, that also increased to 5.5 full-time equivalents. And they still had 1 medical assistant, and then the program coordinator and the program director role went down a bit. So as the nursing and the physicians grew, the coordinator and director role took a little bit more, less of an approach with all the patients, and they had more than 600 active patients.
That's a lot.
Yeah. Okay. Start thinking about all of them like in one room. So for the treatment outcomes, in 12 months of 382 opioid-dependent patients, and they were entering the office-based opioid treatment and primary care. So for in the first red box, you see successful treatment, and that's 196, so 51.3%, about a little bit more than 0.5% of patients overall had successful treatment. 49% of them were treatment retention, so they stayed in treatment, and then after 6 months of a taper, a very small percentage of them were tapered off. So for the most part, half of them had successful treatment. It's pretty good. And then at the bottom, there was a small amount of patients or individuals who transferred to methadone treatment programs. And as we discussed before, we talked about last 2 weeks ago, we talked about like different reasons that someone would do better on methadone. Okay, this right here is a map of buprenorphine waiver physicians in November of 2015. So this data is a couple years old, and I'm sure it has increased over time. But as you can see, places like Pennsylvania and Florida have a really good amount of individuals who are waivered to prescribe buprenorphine, and then in New York and California you also see. So definitely in those states with a lot of individuals, you can see that.
What's interesting is if you look at the map change over time, places that have put real effort in at a state level, you'll see the increases. So, you know, we've seen a slide before about New Mexico and how their number has increased and how they've had better access to treatment as a result. Hopefully in Pennsylvania also, we know that at least the 3 clinicians in the room have been waivered since 2015, actually. So we wouldn't show up on that map, but there are a lot more of us now.
Okay.
And nurse practitioners and PAs are now available. The training's available for them too, and at least at NHCLV, we've got 4 who are waivered, or 3?
3.
Yeah.
4. Yeah,
Mm-hmm.
4. Across our site. And then this one, so the Journal of General and Internal Medicine, Office-Based Manager of Opioid Dependence with buprenorphine. So this talks about clinical practices and barriers that were faced. So they surveyed waiver providers in Massachusetts and to see exactly what the barriers were, and this is what they came up with. So as you can see at the top, there's a lack of support. So there's insufficient nursing support, insufficient office support, and then underneath that you have like payment issues, institutional support, and then insufficient staff knowledge. And then by a small percentage, there's just those housekeeping type of things, so like pharmacy issues that come up, low demand. I don't see that being much of an issue. It's definitely out there.
So it is what we heard originally a couple of years back from Northampton County. You know, we serve a 2-county area, Lehigh and Northampton County, and Northampton original a couple of years back, because there was just not that much demand for buprenorphine in Northampton County.
Mm-hmm. So it's, I think at that point it's kind of like with the question as to what type of efforts are being made to find the individuals.
Mm-hmm.
I think that's definitely.
Or information, right? So we know that there are some of our patients who would say that they don't want buprenorphine because they feel like they're still addicted to something in that case. Lots of education. Anyway, go on. I don't want to interrupt.
Go on. And then below that, there's office staff stigma. That was something that we worked on at NHCLV. So again, that's providing education. So along with providing education to community members and individuals who are suffering with opioid use disorder, it's also education you have to put out into the office too. So education all around for everyone. And then all the way at the bottom is insufficient physician knowledge. So there's a bunch of information out there that you can use to educate yourself. So again, just education all around. So only DEA waivered physicians can prescribe buprenorphine, and this was not for long because as we just discussed a couple minutes ago, right now they expanded it to NPs and PAs, so nurse practitioners, physician assistants can under CARA, which is what CARA stands for again, Certified Addiction Recovery.
I don't remember.
Yeah.
Under that nice act. Yeah.
So that further expands access to treatment. So more providers out there that are able to prescribe it means more access to treatment and care. So that's very important. So what makes the Boston Medical Center MCM OBAT office-based treatment model successful? So they increased patient access to treatment. That's definitely one of the biggest things that they were able to accomplish. They provided frequent follow-ups for patients. There was case management services made available to individuals, and then they were able to address positive urines, insurance issues, any prescription or pharmacy issues. They were also able to address pregnancy, acute pain, surgery, and injury, and then they had concrete service support. So there was intensive treatment, legal, social issues, safety, housing. So they sorry, we're able to give attention to all facets of care in all areas that need to be given attention during treatment. They also had brief counseling, social support, and patient navigation. As we know, that counseling is really important, so to be able to give different opportunities for that throughout treatment is very important. And then support providers also were able to have larger caseloads because they use an interdisciplinary team. Okay, so expansion of BMC OBAT model to Massachusetts community health centers. In 2007, state technical assistant treatment expansion, also known as state OBAT program, created to expand the Boston Medical Center model to community health centers across Massachusetts. So FQHCs, federally qualified health centers, were mandated by Public Health Service Act to provide mental health and substance use treatment, also to provide direct services, and then to measure services for effectiveness and their quality. So programs started with 14 community health centers, and BMC now provides capacity building to over 30 community health centers. So that definitely has increased. So putting these community health centers made sense in Massachusetts, given under that Public Health Service Act that they needed to expand all the treatment to different individuals in their communities. State OBAT initiative and community health centers, and so this were their project goals, and they narrowed it down to access, delivery, and sustainability. For access, they wanted to increase the number of waivered providers. They wanted to increase the number of individuals treated for opioid addiction and integrate addiction treatment into the primary care setting. So overall, expanding treatment and the access to buprenorphine. For delivery and how they were going to do that and how they were planning to do that is they wanted to have an effective delivery model for the buprenorphine. So they modeled it after the nurse care manager program that was used for BMC, and they wanted to focus on high-risk areas and those underserved populations. And of course, the community health centers were the perfect place to do that, being the FQHCs. Sustainability post-program funding. So they wanted to develop a long-term viable funding plan, and they wanted to collect and analyze that outcomes data, again, to be able to take a look at that effectiveness and the quality of what they were doing. So the increased numbers, they increased it up to 10,000 being treated in the community health centers from 2007 to 2014, and with an integration of addiction care into those primary care settings. So they definitely had an increase in the number of individuals getting care. So office-based opioid treatment with buprenorphine, so the OBAT-B, so the statewide implementation of the Massachusetts Collaborative Care Model and Community Health Centers. So they took it another step out, and they were able to cover more areas. So they published the model looking at the benefit of expanding treatment to the community health centers using the nurse care management model and providing technical assistance to support those programs as they were doing that. So the program coordinator, so this is how, these are the different roles that were being played during the Massachusetts model and the OBAT. So the program coordinator, they were able to take the intake calls, so they were screening patients over the phone, and they were able to review the case for appropriateness. The OBAT office-based opioid treatment team were able to review that. The NCM and physician assessment, so the nurse does initial intake visit and collects data, and we'll talk about what exactly that entails in just a second. And then the waiver prescriber will do a physical exam and assess the appropriateness of using medication-assisted treatment. And then also the DSM criteria of opioid disorder, so they reviewed that and they reviewed the appropriateness when it comes to the criteria. The nurse care manager then supervises induction on site, and then they manage the stabilization on and off site, either by phone or by the individual coming into the office for visits. And they are able to follow a protocol with patients self-administering the medication per that prescription they were given after the physician is able to see them. During those nurse care managers, during those inductions, the nurse care managers always followed a protocol. And then they learned that protocol during a one-day buprenorphine training, so they were able to learn about the medication and then able to learn about the protocol and the processes to follow during office visits. During those office visits, they perform patient education and clinical care by following treatment protocols again. So urine drug screens, pill counts, any type of management that has to be done during those visits. They ensure compliance with federal law, so that's by keeping like DEA counts and things like that to make sure that everything is up to date with that. They coordinated care with the prescribers, and they collaborated care with pharmacists, so managing any refills that are needed and any off-site counseling services, make sure that individuals are able to get to those appointments. There was also drop-in hours for urgent care issues, which we discussed yesterday, exactly what that entails, because we were a little curious. And then the NCMs also manage all insurance issues, so example, your prior authorizations. And then on average, the nurse care manager was seeing 75 patients per week. So there's a lot of collaboration going on.
Yeah. Do you want to take just a second? You know, we were talking about this one yesterday because we wanted to kind of compare and contrast what does this nurse care manager model look like compared to what we're doing at NHCLV, and I'd love to hear a little bit about what it's looking like with the pyramid program too. I've heard Colleen LaBelle and her crew talk a lot about some of the expansions that they've had since then too, and it's really exciting work about sort of low barrier MAT access. And there are large pieces of that I think I'd have to see to totally understand. But if you wanted to talk about, I mean, the idea of the nurse care manager model is that a nurse care manager can just help keep the waivered clinicians organized and moving and do a lot of the clinical care and be a lot of the first point of contact so that we improve access that way. So I'm curious about that. Share a little bit.
So at neighborhood health centers, and I think the role has changed over time too, like especially even with like we talked about before, we're having the inductions in the office being something that's under the supervision of a nurse and prescribers that were there during the day. But right now, the work that's being done in the clinic is managing prior authorizations, making sure that patients are able to get their medications. When it comes to DEA counts, that's being monitored weekly or biweekly to make sure that the numbers are even across prescribers, making sure that there's continuity, making sure that patients, when they come in, they do see the same prescriber at least as frequently as we can. Of course, with if someone's out or anything like that, then we have coverage. So making sure that everyone stays on the same page and there's collaboration going on. We also have like nurse-led visits in the office. So just checking in on patients during their especially when they first start out, and then the monthly visits as well to see how patients are doing, and then able to speak with some of the prescribers after that visit and have that collaboration happen during the visit and make sure that patients continue well in their treatment. And if they have like any issues, we address those as well because again, we are primary care. Right. So we do that as well. We don't have much nursing staff out in the community. It's something that we'd like to do in the future. Because right now not just have care managers, we have care managers out in the community, but they be able to have that nursing support, I think would add more for patients, especially because there are other like comorbidities that are being addressed, whether if they have like hepatitis C or anything like that. We want to make sure that patients are able to get to their specialist appointments and get their treatment.
Yeah, so in a lot of ways, we're doing a lot of this, that you're managing the panel and making sure people get to the clinician that they need to see and that the clinicians know who their patients are, right? And all the prior auths and all the rigmarole that has to do with that, and lots of education. And our version, I guess it isn't really drop-in hours, but your visits manage a lot of the overflow. So when we aren't quite able to squeeze everybody in, you're able to kind of help us. So for example, we're seeing a lot of patients tonight because you're helping. What does it look like at Pyramid? At Pyramid, we have the doc, so all of our MAT prescribers are physicians, and we have a medical assistant who really helps us with logistics. So we have a nurse who does a nursing assessment on each new client, and who does a whole bunch of the consent pieces and the history and gets their meds into the chart. And she also can do the Vivitrol injections. So some patients just see her and then come to us for sort of a check-in. So it's really mostly a medical assistant who's helping us with initiating prior auth, so filling out as much as she can of prior auth, calling the insurance companies, getting the Vivitrol out for the day, keeping track of, all of those meds, setting up the next appointment. So it's a little bit of a different model. We really don't have a nurse that is sort of folded in with the MEP provider. It's sort of done separately. So it's just an interesting, it's sort of done in stages where you have a level of care assessment and then a nursing visit, then a separate MEP visit. And the MA kind of is the communicator between all of those pieces. So I wonder what it would be like to have that nurse role kind of more present in the sort of day-to-day of the MAT clinic. Different approach.
Cool, thanks.
Okay, so for Massachusetts model again of the OBOT maintenance treatment, so patient care, so at least 6 months of visits. So the nurse care manager visits were weekly for at least 4 to 6 weeks, and then once every 2 weeks, and then once every 1 to 3 months, and as needed afterwards. And then each patient is able to see the waiver provider at least every 4 months, if not more. So there definitely is there's collaboration between the nurse and the prescriber. And again, as you can see, because they have those NCM visits at the beginning, weekly and biweekly, you can see how that helps build a patient panel on the provider side. They're able to have more patients. Medically supervised withdrawals were considered based on stability. The patient requested a taper, so if a patient was requested a taper, they would any type of withdrawal would be supervised to make sure.
And it sounds like they're doing less and less of that as it becomes more clear that that's not often a successful strategy for people.
Yeah, and even before the number was really small, I think it was like 6 individuals.
Yeah, that's right.
2%. And then for those transferred to methadone, if they continue to use any illicit drug use, or they need some more structured care, as we talked about last time, those methadone offices can now offer visits every single day. And then disruptive behavior was given attention as well. So if they discharged for any disruptive behavior.
So I think all of our offices and you guys out there may comment on this too. I think that when we take this on and take on the harm reduction approach, our first priority is on de-escalation. And so hopefully if we're good at what we do, disruptive behavior becomes less and less of an issue. But when people are coming in withdrawal, we know that they're not always at their best. So we de-escalate.
Yeah, and that comes, and I think that also comes with like education for the entire office staff too, to educate them on what withdrawal looks like, why someone's going to withdrawal. And that way they're able to understand it a little bit more and have a little bit more empathy when it comes to patients coming into the office and withdrawal.
Yeah, and I think that's one of the key skills for an office that's taking this on is to have the whole team, whole office staff approach to de-escalating a patient and understanding how to monitor your own emotions while that's happening, because we can actually handle a lot more than we think we can when we get started, right?
University of Massachusetts study findings in Massachusetts. So they studied 5,600 health clients prescribed buprenorphine and methadone between 2003 and 2007. Overall, the expenditures were lower than for those with no treatment. So we see that MAT does help with expenditure too, cheaper. Clients on medications had significantly lower rates of relapse, hospitalizations, and ED visits. So it was no more costly than other treatments. Because as we know, hospitalizations, ED visits, those cost money. So if someone's going to the hospital less and they're going through it, and the relapse rate is lower, then we're saving in the long run. Buprenorphine, also they noticed was attracting younger and newer clients to treatment, and I think that's what we've seen in our office too. Probably what you guys see as well at Pyramid. So for the nursing assessment, so during that intake assessment, and this looks a lot like what you guys were talking about at Pyramid, or what you guys have going. So going over like medical history, treatment history, any pain issues, mental health, co-occurring use, and medications. So getting a good picture of the patient and what their treatment's going to look like. Program expectations, so visits and frequency, any urine drug screens, going over the consent and treatment agreements to discuss like behavior in the office, and then also coming to visits, pretty much like those housekeeping rules. Understanding of medication, so they want to understand that you want to make sure that individuals know the potential for withdrawal, and they know about the medication that they're taking, and then also to review, sign, and make sure that everyone has a copy of that patient's copy of those agreements and those consents that are given, so they can be reviewed at a later date. For education, so you want to give education on the medication that they're taking, on the administration, how to store it, how to safely store it, to make sure that you're keeping it in a safe place away from others. You want to make sure that it's not lost or stolen. And then also responsibilities on the treatment plan. So you need to make sure that you make it to all your visits on time. If we've discussed like counseling as part of your treatment plan, you need to make sure that you go to all your counseling visits. And I think this also is a good opportunity to make sure that the team has all those contacts for all those counseling places, to make sure there's collaboration going on with that, because that has been extremely helpful for us. And then again, urine drug screen, and then learn liver function tests, hepatitis testing, RBR, CBC, pregnancy tests, so all the lab work that needs to be done.
Yeah, we include an HIV test in there. I know you guys do too. Yeah.
Mm-hmm.
I think they do too.
The whole list. They just couldn't stay on the line. So for the waiver provider, so they review the history, they review the mental health, substance use, medical, social. They do a physical exam. They review labs, with the labs that we just listed. You want to assess any contraindications for the medications, toxicology. You want to confirm the opioid use disorder diagnosis, so referencing that DSM-5 criteria and making sure that the patient qualifies for that. You want to confirm the appropriateness for the office treatment. You want to see if they need more structure, then maybe a referral to where methadone would be something that would work better for the patient. So assessing all areas of their care and their environment. They sign the order and the prescription, and then they develop the treatment plan with the team. And then after that, then the induction preparation. So their inductions were done in office. So that was opportunity for the nurse to review program requirements. They want to make sure they have appointments that are scheduled, that the frequency is correct, the times, location, making sure the patient knows exactly where they need to be and when they need to be there. Counseling, it's going to be weekly initially, so make sure they have those appointments. They know who they're going to be seeing. They discuss the in-office urine drug screen, so those are going to be done at visits, and then there's also going to be callbacks. So if there's going to be a random, they would get a phone call. For abstinence, they would discuss the abstinence from opioids is the goal. And then this is also the opportunity to make sure that insurance is verified, prior authorizations are done, patients are able to pay those copays, and then also safety. So talking about medication storage and keeping it safe and away from others and only using it for themselves, not sharing, things like that. So on induction day, the instructions that are given to the patient is, so after insurance verification, they want to discuss disposing of any paraphernalia, any phone numbers or contacts of those that they used to have contacts with. So pretty much to do an entire cleanse of any like physical options they would have around them, around in the home or on their person. They have a medication pickup, so here it's like 2 milligram or 8 milligram tab. So whichever dose they were on, they will pick that up. They are instructed to not do any driving for 24 hours, and they want to make sure that they are ready to be at the clinic for 2 to 4 hours. So this will be a lengthy visit to make sure that it's at a date and time that they're able to stay for a longer period of time. You want to bring a support person if possible and discuss any potential side effects and precipitating withdrawal they may experience during that visit. These the follow-up visits, what they consist of is assessing dose, frequency. For frequency, are they still experiencing any cravings or withdrawal? Education is ongoing. There's always an opportunity for education when it comes to MEP and office-based treatment. So education on dosing, side effects, interactions, etc. Counseling, self-help check-in. So check in and see how they're doing with their goals. Like have short-term goals, long-term goals. Where are you at in accomplishing those? For psychiatric evaluation, that follow-up is as needed. So the nurse can coordinate that as well. They can also address any medical issues, meaning if they have any vaccines or follow-up for any, like in this case, would be like primary care, things that need to be addressed, get follow-up visits for that planned. If they have HIV or hepatitis C, make sure that they're engaged in treatment and engaged in their care. You can also assist with preparing prescriptions, so making sure that they have their prescriptions and they take them to the pharmacy, using the same pharmacy consistently, facilitating prior approvals in pharmacy again. If a patient were to be pregnant, then they are engaged in appropriate care. And if referrals need to be made, then those are made. And then social support, so always checking in on housing, job, family, friends, etc. This right here talks about hospital admissions, so average hospital admissions per OBOT enrollment. So the blue is the prior 6 months, so you can see those numbers were higher, and then in the first 6 months, and then the 7 to 12 month range, those numbers were significantly decreased than prior to that. So you can see the hospital admissions had a big decrease from 2008 to 2011. For ER visits, that also decreased significantly. So again, the blue is prior 6 months with the from future 6 months to 12 months being in red and green as well. So that number significantly decreased in those 4 years from 2008 to 2011. So social determinants of health and substance use disorders. We all know the health determinants contribute to biological, socioeconomic, and psychosocial status. It's more than just the physical and mental that you see in the office when they come in. You have to take a lot more into consideration. You take their environment into consideration. If they're living in a shelter or they're homeless, then they're not going to have a safe place to put their medication. So a lot of things go into that. Employment, if they are unable to have enough money to pay for co-pays, then getting insurance or if they don't have insurance, then that's also going to make things a little bit more difficult. So you need to plan for that. Access to healthcare and access to emergency care, social stressors. So if they're in an abusive relationship or they're neglected or they're unable to get food every day, then these are things that they're not going to be able to focus on their care if they're hungry or if they don't know where they're going to sleep that night. Educational disparities can lead to issues with occupation and maintaining employment, mental health issues, cultural norms, so attitudes, treatment settings, decision making. The attitude, especially with like buprenorphine, if they don't believe that itself is counting as sobriety, then that's going to be something they're going to struggle with during their treatment. So you want to address the causal chain in substance use disorder. You want to make sure that they have supportive housing, they have career development goals, see if there's job training in the community, or if you're able to get them into some form of like schooling or to help with that. Universal health care, so reinforce prevention and treatment.
Gosh darn Massachusetts with its universal access. Yeah. But we love that. Universal design. We'll do prevention for everyone. We can take that part.
For stressors and support, to make sure that they have support in place, and then prevention and education. So just making sure that there's social connectedness between the individual and their community and their social circle as well. For complex care management and opioid use disorder, so patient-level outcomes are comparable to physician-centered approaches. They allow for efficient use of physician time to focus on patient management. So that would mean like your dose adjustments, the maintenance visits, taper if it is used, and then it makes it so those panels can be larger. So if you're able to see more patients and you're able to reach more of the community, you want to increase that. It was able to improve and increase the access to office-based treatment and daily management of also like the housing, employment, health insurance as well. So now that they're coming for care, they're able to get some help with those other parts of their care as well. And then this right here is like MEP Training. So this is a really good website and a resource that can be used. You can find a mentor. So if you're in an area where it's not a lot of providers around you, you can ask questions to or anything like that. You can just go online and find a mentor to be able to have some support while you're doing some office-based treatment. There's webinars that have different topics that you can reference, and then there's modules too that you can use to kind of keep in the know when it comes to MAT and office-based treatment.
And Pennsylvania has a pretty good network in the PCCS group, so they're a really useful network, and the state's been working with them successfully to help train trainers and get more buprenorphine training out there. So this has been a great resource. So nurse model. I think, you know, in my view, having a nurse care manager role, I can't imagine us really doing it without it. It's interesting that you guys are able to do something else, but I love the suggestion from the Boston folks that, you know, when you have nurse care management, you can actually really expand access and expand the reach of programs like this. So we're trying. We've tried to design this way. We've had to make our own adaptations and still have more way to go as we figure out what works locally. Power of nursing. Anybody out in the call zone have any questions or comments?
Yeah, this is Phil from up in Schuylkill. You talked about the importance of the office staff training, from the de-escalation just through the overall process of office-based treatment. Are there programs available? Are there resources available on that, or is that kind of a model that just is put together based upon what you might feel is a need? Like, are there preset programs for that, if you will, or resources, or is that kind of on the fly depending on what we feel is important for office staff people to have?
That's a great question. I think there are a couple of different perspectives that come into play there, and I think there are some organizations that have some decent checklists of what's your readiness to start providing services. Most of those probably focus, Bill, on what's your readiness to provide trauma-informed care, and that can be really helpful just to sort of have the basic skill sets of how, you know, since the paradigm shift for a lot of primary care offices, at least, is going from a treatment model to a harm reduction model, that takes a lot of training for people to be able to manage the internal emotions of that change, right? Because it's not the same. We're not doing what we thought we were trained to do. We're doing something a little different that makes us more effective. So in primary care, I think there's a lot of need for training in trauma-informed care and harm reduction. Another set of tools that's available on the SAMHSA website is about interdisciplinary team care, particularly in primary care offices. And Lynn and the GWEP team can probably speak to this some, that working in interdisciplinary teams also is a little bit of a paradigm shift for a lot of primary care offices or for healthcare services in general. So what does it mean to have a nurse who's really working to the top of his or her license? What does it mean to have case managers in the office that can gather a lot of information and story for people that we might not otherwise know? So similarly, at the SAMHSA website has great stuff
to talk about that. But I think each organization needs to take a good look at what resources do they already have available, and spend some time talking to the staff about what are some of the concerns that they may have about implementing a new model of care, and then design some training around that. Does that help?
It does.
I think using like individuals out in the community too. So like we were able to find like at the Bethlehem Fire Department, they provide like Narcan training. So they're able, they're able to come in and provide Narcan training to all our sites, and they were more than happy to do that. So being able to do that, and I think having someone come in from the outside too also makes it, gives the staff is able to understand that it is like really important, because it's more than just like between our own walls. It's something that goes on outside of us too. So if they're coming in to do that for us, then it means it's a community issue and not just an issue for ourselves. So I think taking advantage of those community resources and searching for them is really important too. And it builds partnerships again. So in the end, that's always important.
I think one nice model that's out there still is the RAMP model.
Yeah.
So rural access,
Particularly for Bill,
PA.
right?
Yeah. So I mean, that too, I think, is going to come up to your site and to the primarily it's the family practice next door for Dr. Mady. I think what we've decided to do at LVHN is to basically take their model and to try to use that broadly across the network. Abby and I reviewed their model, and we had edits and little tweaks that we would make, but then we decided, you know what, if we just leave it as is, as a sort of a standard protocol, there are a bunch of different tweaks that we could all make to any protocol about little nuances in terms of the way we do Vivitrol or Suboxone or inductions. We decided just to keep it as is. We're sending it to leadership for approval, but once approved, our plan would be to use that at any primary care site, LVPG site, that wants to do MAT and Vivitrol. The one caveat is that what RAMP does is they come out and they come to the office and they train the staff in the protocol. So how you replicate that at a site that isn't rural, officially rural, so obviously Schuylkill will do that. They agreed to do Hamburg, and they agreed to do Hazelton. But beyond that, what we're doing is basically an echo, like a WebEx, where we're going to get that education out to other offices. Because it sounds like that's valuable education for the office staff, but it makes us realize that it's nice to have that packaged. It'd be nice if RAMP continued to expand. They're sort of relaxing what they consider rural. And they're very comfortable with us using their protocol and WebExing their education. But it shows me, I think, that there's a gap in terms of needing sort of a package almost to help train a new staff.
Right, so specifically about the workflows and protocols. Yeah. And then on top of that, some of the things that we were talking about is the team-based care. No matter what the workflow is, if you don't start working on some of the attitudes and skills of working in an interdisciplinary team, those workflows that depend on an interdisciplinary team may not work.
Right.
And if you're not ready for trauma-informed care and harm reduction, I think the team as a whole may create a lot of internal agony. So, yeah, but there's a lot of work to do, I think, to implement a new program, and it can work.
Right.
Yeah. Thanks for bringing up the RAMP resources. Those are great.
Yeah.
Any other questions or comments?
Abby. This is Lynn. So I just wanted to make a comment kind of on the interdisciplinary team piece. One of the things that we learned when we were working with the GWEP team in bringing nurses together with community health workers, which really was not a common model. The biggest thing that we found is building relationships between your team members, but also to clearly delineate roles and responsibilities. And and realizing that if you've delineated overlapping roles and responsibilities, you need to make sure that you know, we have one person versus another who can kind of be the lead for that. And so I'm sure Judy and Luz, who are our nurse and our community health worker, can talk about it, you know, in greater detail than I can. But I know from my perspective, it was really all about making sure that we were clear about who was doing what and when.
Judy or Luz, do you want to talk about if you can think to the early days of your roles at GWEP, what were some of the key things that helped you start doing this work in an interdisciplinary team? That's a big shift for a lot of us, and I think in our team at NHCLV also, you know, a lot of case managers are trained to work on their own, and working in a team is tough. So tell us, what are your pearls of wisdom?
So I feel that trusting your colleagues and exercising as a nurse, you know, being able to delegate the things that you can to be able to get more work done and more effectively. And I just think that trust is a huge issue. You know, trusting that that person that you're giving that task to is able to complete that. So that's how me and Luz were able to work together and, you know, be able to get more done like that.
Thanks, Judy. Luz, what would you say was the most important shift for you?
Well, Judy is my nurse number 5. So not all the nurses are like that. I mean, I don't have, but at first it wasn't easy with the other nurse that I had because she wasn't clear coming in community health workers, the credentials, and like Judy was saying, the trust. So after you develop the trust, and when the nurses know what the community health worker is able to do, it's much better.
How did you, Luz, so you've worked with 5 nurses. How do you train the nurses how to work with a community health worker?
Well, what happened is that we have some changes in nurses. So, like I was saying, my first nurse was a little trust issue. Nurses, with all the respect, and I always say that, they're a little jealous of their job. So it's not that I want to do their job, but I just want to show them that I knew what I was doing. I came with a lot of experience from the community, and I have to show them that I knew what, like I say, what I was doing, that I was competent too.
Mm-hmm. That's great. Jasmine, do you have any thoughts at all about, in the similar way of the community health worker can help to train the nurses to develop that trust and to be good delegators? What have you had to do with the doctors at NHCLV so that we work with you?
I think, and like Luz mentioned, it is tough at first. Judy also mentioned it too. It is tough at first to gain trust, and I think that once everyone is aware of each other's roles and what experiences they have, and they're able to hone those in, then I think it's easier to have an exchange of that and to make sure that care gets done with that exchange. At NHCLV, I think I've been able to develop a lot of education for myself over time. A lot has been learned, and I think that also helps with the relationship as well, because we can learn a lot from each other. And I think making sure that things they organize something is needed to make sure that it's said and things like that, and going back and forth too. So if something needs to be done, then we have to communicate about that and make sure that it does happen. And I think overall that's something that we've been able to develop.
Mm-hmm. Great. Other thoughts or comments?
I mean, I think just overall, it's being presented today about the importance of utilizing the nursing staff and not seeing them as support staff. They are the providers at that point in time, and giving them, that open door to just trusting them to provide the correct treatment at that moment and taking care of the patient as the patient needs to be, and having the meetings with the you know, you guys as the doctors once a month, that's great. Because then, like you said, we're expanding the service. We're getting more people seen. We're getting the MAT to more individuals that, I mean, in this area is highly needed. You know, we call, make an appointment, and we're still waiting a month, and hopefully, little by little, you know, that time frame gets smaller and smaller, because many of them come in and it's today or tomorrow you could be dead. Like it can really be that quick. So hopefully, as more physicians get trained and more nursing staff becomes comfortable with taking on those responsibilities of seeing patients in between your appointments, we can just get more people in and save more lives.
Yeah, I think that's the call, right? Great. So I've been trying to multitask over here. I don't actually have the slide template. Lynn has a great case for us today. And what we were planning on doing, Lynn, is sort of filling in the slides as we go so that we would have a record of it, but I don't have the slide template. So what I would say is, Lynn, if you want to just sort of tell us about your case, we will be looking at our slides and filling them in, and we'll give you any prompts if you feel like you're a little stuck. I'm sure you're going to be great.
Sure.
And I just want to say to the group as a whole, thank you, Lynn, for responding as I walked past your desk at 11:45 and said, Lynn, you got a good case? And putting a little bit of thought into it and making it happen. And what I'd love to suggest for the rest of the crew out there, this includes not just the doctors, but all of us, as Melissa just mentioned, we're all the provider at the moment that we're providing the care. So any of you at any time, any case, something that's on your mind is going to be wonderful, and you're about to see how wonderful somewhat impromptu case is from Lynn. So thanks, Lynn, for having good guts.
Sure. So this is a 28-year-old Hispanic female. She was actually assigned to me as the PCP, but I had never met her until I admitted her to the hospital inpatient unit at Cedar Crest. So she was admitted with a rib abscess. She had some back pain and was admitted with what turned out to be a methicillin-sensitive Staph aureus rib abscess, the left posterior rib. Let's see. She had been in treatment previously. She had been seen at Pyramid a little over a year prior to her admission. And she had been on Vivitrol successfully for about 7 or 8 months with a relapse to heroin and the subsequent abscess formation. Other than that, she had a diagnosis of bipolar type 1 and a history of prior sexual and physical abuse during her youth. She had 2 children, so she had a 12-year-old and a 10-year-old. Both were in the care of her parents at the time of her admission. She presented to the admission with her current partner, girlfriend, who was supportive of her accessing treatment and with whom she was currently residing. Let's see.
What do you know about, prior to her relapse, what do you know about her drug use history? Do you know how it got started?
She said started mostly with marijuana in her early teens, 12 or 13 years old. Her drug of choice was heroin. She had dabbled in some cocaine use previously as well.
Do you know what her maximum use was of the heroin?
I believe she was at 5 bags a day.
Okay. Awesome. Okay. So far, we've had a pretty long drug use history. Do you know if she was injecting or how was she administering the heroin?
Most recently, she was injecting. When she started, she was snorting.
All right. And had she had any other medical complications of the drug use before this rib abscess?
Not that I'm aware of.
Okay. So you admitted her for a rib abscess.
Mm-hmm.
She had a recent relapse. She'd been doing OCAN Vivitrol.
Correct.
Was at Pyramid. I think you'd mentioned that she'd stopped going to Pyramid. Was that for a reason other than the relapse or just plain relapse?
It was because of the relapse. And she told me several times that she felt ashamed to go back.
Okay. That's always a heartbreaking phrase, right?
Mm-hmm.
All right. And then what happened?
So we, got her on her antibiotics towards the end of her hospital stay when we were transitioning her antibiotics to by mouth so that she could be discharged. We actually got the medical toxicologist involved at Valley Cedar Crest to come and see her. She's on a pain regimen at the hospital. I didn't feel comfortable giving her any sort of prescription narcotic to take home with her, but I was also aware that, A, she was going to have pain from her rib abscess, and B, if we sent her with nothing, that she was going to use again to self-medicate. So I asked, with her permission, I asked them to come and start her on Suboxone. She did tell me that her reluctance to start Suboxone was that she felt like that was another addiction, that she was just switching one for the other. And I kind of presented it to her like it was a bridge to get her from her current inpatient status, requiring narcotics for pain control, to an outpatient status where she could then, reestablish herself with Pyramid, and if she wanted, detox from the Suboxone and go back on her Vivitrol once her medical condition had stabilized.
How did those conversations go?
It took us probably a good 2.5 days, but at the end of the 2 days, she was agreeable to talk to the medical toxicology team. The medical toxicology team came. They did agree with my reasoning, and so she was started on Suboxone. She was stopped from her narcotics and started on Suboxone once she started to withdraw, while she was still in the hospital. From there, the plan was to give her enough for a few days so that she could reestablish with Pyramid, to continue on the Suboxone for the short term. Unfortunately, once she was discharged with her short course of Suboxone, she did not go to Pyramid to reestablish. She used the Suboxone that she had, and once she ran out, she went back to using heroin. So when I saw her for her 1-week follow-up after her discharge from the hospital, she was, again, actively using, and came to our office to request pain control for her rib abscess. That clinical encounter didn't go very well. She was very hostile and aggressive during the encounter. When I told her that I was not prescribing her any narcotics, during that encounter, that I would be happy to make a phone call to Pyramid, they could get her in the same day. She stormed out of the office. And so I was telling Abby this story because I said that I felt a little bit sad. I felt that I had done what I could to establish a connection with her. I felt like at the hospital we had a good relationship. And then when I saw her in the office, when she was actively using, it was a very different situation. And so some of that goes back to kind of what you all were saying about, you know, how do you train someone to deal with people who, you know, when they're not at their best.
Yeah, there are emotions involved, right?
Yeah.
Right. And have you seen her since that 1 week follow-up visit?
I have not. I know that I do get the updates, you know, through the chart on her. So I know that she did see one of my partners, inquired again about going to Pyramid, and he had given her all the information and called over to let them know. And I did see within the last few months that she was admitted to St. Luke's, and was currently using, and the note indicated that she had it, that her latest relationship had dissolved. So her support person was no longer in her life.
Hard things to read about from a distance, I'm sure.
Yes.
Yeah. Okay, we ready for some clarifying questions? Do people out on the, so if we can try and summarize that one pretty quickly. She's a 28-year-old with a history of some polysubstance use and heroin use disorder for several years, with injection drug use, a co-occurring diagnosis of bipolar disorder, and a history of sexual and physical abuse, who had suffered a relapse, and as a consequence of that, developed a rib abscess and was admitted to the hospital. Had issues the main issues in the hospital, and the goals of the hospital team were pain management and relapse prevention. The toxicology team came in and provided Suboxone induction, but the follow-through care didn't go as planned, and she relapsed and has not been successful in engaging in care since then. Is that right? Okay.
Yep.
So clarifying questions from people. I think these probably aren't helping. So you can unshare. Any clarifying questions from people out on the network?
I'm assuming then that at this point in time, to the best of our knowledge, she's not re-involved herself in substance use disorder stuff or mental. I believe she had a bipolar disorder.
Correct. Yes.
And anyone can have a question, including people who are observing, if they like. What makes you curious about this patient?
Hello.
Hi, Luz.
Hi, this is Luz. That was a 28-year-old with it's a lot of things going on. It's a tough situation, and I don't know, I'm just thinking that maybe what it triggers is that finally she has the support and wasn't there. So I think that triggers this whole situation. and she was almost there, but what happened? You think the same thing mean? That maybe can be one of the problems right there. Maybe.
Yeah, I think that, I think that she was so close, from my perspective, to getting to a point where she, and what she had named as her goal, she and her partner both had said that their goal was for her to be clean. But I think, in some ways, her definition of being clean was to be off of the Suboxone as well. And I was not able to kind of overcome her view of the Suboxone as just another drug, and a drug that wasn't making her feel better. She obviously felt better on heroin than she did using the Suboxone. So I think that some of it was that. I do wonder how much of her most recent hospital stay with her relapse had to do with her supportive partner no longer being in the picture. And I don't know if that was because she was back to actively using, or if it had nothing to do with that. But that loss of that support person struck me as something that would be significant for her.
Great question, thanks. Other questions out there? Courtney, you got a question? Don't have to.
I was just wondering, did you try offering a CRS to go talk to her or meet with her?
I did not. I'm not even, and I'm not entirely sure if that's an option at the hospital.
You can always just fill out a referral form, and they can contact her by phone.
Okay. Yeah, that's good to know. It's not something that we had, but I will squirrel that away for future reference.
Yeah, you can reach out to Confront or Pyramid.
Okay, great.
Right, and Courtney, wouldn't you say that over the last 2 or 3 years, we've been recognizing more and more what an important role the CRS has, yeah, particularly for patients just like this, right? In that moment, that kind of moment between an acute medical something or other happens and yet not quite engaged in treatment yet. Can you talk about that?
They've been going on, I think we aired it about a year ago, and a lot of people that are struggling, they're not sure if they want to get treatment or whatnot. Just having somebody there to talk to them, for a couple weeks, usually are able to talk them into treatment eventually. Sometimes we're not successful, but it's a lot more successful than having nobody talking to them and nobody following up with them. So it's worth a try.
Thanks, Courtney. How about in the room, clarifying questions? We'll go around the table. We'll start with Jeff.
What type, so I know you mentioned that the support person that was there, does she have other support systems in place? And it's not necessarily just like family or friends or anything like that, but is she involved in any other type of like programs in the community? Has she gone to like different meetings or things like that? I know you mentioned Pyramid. Was she in other meetings prior to that?
No, the only meetings that she ever told me that she went to were all part of her Pyramid kind of group. So she had done a detox there and then started in their Vivitrol program and went to the support group meetings at Pyramid. She had her partner. She did tell me about a younger sister who was also using, and so was not a great support for her. The two of them actually kind of sounded like got together and used together. Her parents were caring for her children, and she did tell me numerous times that her kids were the reason that she wanted to stay alive her kids were the reason that she wanted to get treatment. And I did ask her if her kids were aware of what was going on. And she said that they were mostly. But I know that the weekend she was to be discharged was her son's birthday. And so her goal was to get home so that she could be there for that celebration. But those were the only people that she really talked about engaging with or having any sort of relationship with.
Sounds lonely. That moment when you described her storming out, what do you think was, did you have a sense of what was really at the root of that?
I think part of it was that she thought she was going to be able to come into the visit and say, I tried the Suboxone thing that you told me about, it didn't work. This is what you need to do for me now, so that I won't go use. And she was really kind of trying to hold that over my head and say, well, if you don't give me some oxys, I'm just going to go shoot up heroin again. And, you know, when I said that my job was to really help keep her as safe as possible, it was not to just give her whatever she wanted. That was when she stormed out, saying that I was killing her.
Ouch. Yeah, it's tough.
We've been there too.
Yeah.
Any legal involvement or children and youth involvement? Any agencies that could help in getting her into treatment?
Children and youth, it sounded like, had been involved in the past, but was not currently involved since she did not have custody. She only had visitation. But she didn't disclose to me that there was any sort of legal involvement or legal issues.
Okay, so now, I mean, her case obviously being presented because you're concerned for her well-being. Are you able to reach her again? I mean, I know it sounds like she was accessing treatment through St. Luke's. Has she been anywhere else in the network that,
no,
even if we were to give suggestions, we'd be able to get them to her?
The last time I tried following up on her phone, it was disconnected. So the number that I have for her was no longer in service. And she has not, as far as I can tell, reached out and had any medical care since the St. Luke's ER visit.
Okay, so is her case being presented as a lesson for future cases?
That, and, you know, it was one of those things where, you know, I guess I was asking Abby, what should I have done? What could I have done there to make things different?
And you never know when people show
come
up.
back.
Right. No, and just wondering, you know, like whether, you know, the suggestions are going to be, let's hope she comes back, this is what we can do, or this is what we could have done differently to learn from what happened, or this is the suggestions that we're giving to get this individual help. Like, I just wanted to know when we get to that part, I know what I'm.
Yeah. Yeah. My hope is that she will re-engage when she is ready, and before it's too late. But also, you know, from my learning is, what should I have done differently in this case to make the outcome better?
Yeah.
I told Abby, I left that day from the hospital thinking, like, we got it set up. We've got all these things in place. She's going to do all these great things. And it just didn't work out that way.
So Lynn, this is, thank you so much for sharing that. You're starting to go with what I'm wondering. And folks, if this is too much of a digression, please tell me. But what I'm wondering about is you and how you kind of coped and like internally and externally with that situation. I mean, how did you manage yourself there? what kind of, did you have, I don't know, do you have people that you talk to there in your office? You know, how did you react?
Yeah, I mean, I think that's a big thing. So, you know, the first thing that it came back to, particularly in that moment when I had seen her at the follow-up visit and she had screamed at me, was that it felt really personal. And so I needed to take a step back and remember that this wasn't about me. That whole visit had nothing to do with me as a provider. It had nothing to do with me as a person. That was her addicted to drugs and using, and in my opinion, afraid. And so, you know, I think that, you know, that was the message that I had to kind of keep reminding myself, is that although this felt very personal, it wasn't about me. This was about her fighting her demons. I was just there trying to keep her as safe as possible while she did it. You know, and I will say that anytime you have some sort of outcome with a patient that wasn't what you hoped for, or wasn't what you expected, you kind of feel like maybe there was something more you should have done, or something more that you could have done. And I think that bringing it to a place like this is really helpful, because it does give you a few pointers that maybe next time I can do, you know, calling the CRS to put a phone call out to that person that I know is high risk, or involving the team a little bit earlier in those discussions. But, you know, also kind of validating that you do the best that you can, but people are not always ready to accept the help that you want to provide them, or that you can provide them.
And thank you again. How do you suspect you were able to so quickly get to that kind of cognitive schema? Is that just part of your routine medical training, or I mean, not everyone's able to so quickly say to themselves, okay, this is about the patient and not me?
Yeah, I think, you know, some of it comes from spending a lot of time in geriatrics and palliative medicine. There are a lot of people who get upset, and I have had to quickly realize that, you know, that's not about me. I think, you know, Abby and I were talking about it earlier. I think that there are places now where they're doing a better job of training our medical students to identify what is the conflict here. You know, our USF students are practicing that in their first and second years, which is amazing to me, because it definitely didn't come naturally to me, and it still doesn't always. Like I said, I really had to take a step back and remind myself of that. Even though you know it, you still feel bad. You still feel that kind of sinking sensation in your gut, that you have let someone down or disappointed them. And then I talked to Abby, because Abby is a great resource.
Abby fixes the law. What questions do you have, Mackenzie?
Oh boy. The questions that I had, it's, I guess, kind of, I find myself asking these questions a lot, kind of trying to defray the blame that you place on yourself, so that you feel like less of a failure in those kind of situations. Because I think I still don't have the experience to be able to step back, even with that training. I think that that's something that is only going to come with time. But so the questions that I had were, what kind of mental health treatment had she gotten in the past? And then I know that we talked about how she was living with a girlfriend previously, but what kind of home environment and financial kind of security did she have?
So she had some psychiatric treatment in the past, during her late teen years, after the birth of her children. And even in her early 20s had been on some antipsychotic medications for the diagnosis of bipolar disorder. She said she didn't like the way it made her feel, and had discontinued them all on her own, and was not really interested in psychiatry or behavioral health outpatient follow-up other than, kind of addiction treatment. As far as her home life, it sounds like she and her sister had both been physically and sexually abused as kids, and I'm not sure who the person was. We did not ever get into, whether it was someone inside the home, outside the home, known to her or not. But, her story basically was that she and her sister both had similar experiences, which was part of their using together. She was not employed, so I know that her financial situation was a struggle.
I don't know if it was mentioned prior, but so she doesn't have a job now, but prior to that, did she ever have a job? Did she go to school or anything like that? She graduated high school. If she did she go on to take some classes or something? Does she ever have a goal of staying a career or anything like that?
Yeah, I don't know if she ever had a job, to be perfectly honest. And I think she'd gotten her GED, but she had not gone past that. Because she had her kids at 16 and 18, or 16 and 17.
Sounds like there's an awful lot going on for this young woman. I'm curious about a couple of things. One thing I want to know from your impression of her, what would you say her strengths are?
Honestly, she was just a strong individual. She had survived a lot. And she and I talked about that several times through the course of the hospitalization, was how she had really kind of overcome this history of abuse and trauma in her childhood and teenage pregnancy, and, that she was a survivor of all of these things. So she really was she had a very strong personality, but she was also a very strong person. And I think that she had a lot of insight, actually, into herself when she was sober. She had a lot of insight into why she did the things that she was doing. And she was well aware that her coping mechanisms were not healthy, but seemed unable to break that cycle.
When the two of you talked a little bit about her goal of staying away from the opioids and getting deeper into recovery, was she able to talk about what that might look like for her? Any specific kind of ideas of what might come as a result of that for her?
A couple of things that she was hoping would happen would be increased visitation with her kids and possible reinstatement of her family unit. Like I said, most of her recovery kind of dreams went back to her kids and being a better mom for her kids than she had.
And I think my last question has to do with her sister. You mentioned that they use together. Sounds like they have a lot of shared experiences. Did she ever talk about what was at stake if she wasn't using in terms of her relationship with her sister?
So I asked her what her relationship with her sister had been when she was at Pyramid using the Vivitrol and in recovery. And they basically didn't speak at all. She said that she had to really cut off ties with her, had actually moved in with her girlfriend, had moved away from her sister intentionally to try and move away from the areas where she was commonly to use. It sounds like had pretty much severed that relationship until she had relapsed.
Great. Okay, any other clarifying questions out there in here?
I have one. I'm wondering, given that the motivation for of her children was so strong, I wonder if Lynn or anybody, if you have thoughts about how they might have been invoked in that last discussion as something to help kind of remotivate or redirect the discussion in a productive way.
Yeah, I'm not entirely sure. It was not the most, she was not the most receptive at that point to listening to someone else, unless I was just going to blindly say yes to whatever she was demanding. It wasn't really a conversation.
Did they visit her in the hospital, Lynn?
No, she did not want them to visit her. She said, in this state.
Uh-huh. Okay. All right, let's shift over to some suggestions. And as usual, we'll start with our suggestions with the folks out on the line. And I think Yamalisa brought up some good sort of distinctions that we're welcoming suggestions across the range that might be focusing on reframing for Lynn, because that's, you know, what the heck? That's the hard chore that Lynn has at hand for her own process, but also what could have happened differently? What are resources that you would think of to suggest either while she was in the hospital or during that one outpatient visit? And what do you think might be helpful just in case she shows up again? And do you have any tricks up your sleeve for how somebody might actually find her? So that sort of range, if you have other kinds of suggestions, I think that's great as well. Who would like to start? Out there in Zoom land? Suggestions for Lynn.
Hello, this is Luz. I don't know if this is correctly, but I think when she was at the hospital, maybe be more aggressive with the social work and the case management to get more information and from her and how they can help her as soon as she was transitioned to the program. Maybe that was a good idea. I don't know if that can be possible.
Right. So the toxicology team was consulted, and it'll be interesting for us to hear from our toxicology team just what does that involve and what kind of linkages are available. So that'll be great to hear about. Great question, Lucy. And Lynn, if you want to talk about anything that, you know, what were you aware of that when the toxicology team came? We know that they did the induction. What else happened during that stay that helped to make a link?
I know that, you know, they sent the referral information over to Pyramid on her behalf and had not set her up I guess a loose appointment, we'll say, you know, so that, because I think she was being discharged on a Saturday. So she was to go to Pyramid Monday, like late morning, early afternoon for her intake. So I know that they did set that piece up for her as well. And they gave her a prescription for her Suboxone for Saturday night and Sunday. and I believe Monday morning as well.
Great. Some suggestions?
Yeah, this is Bill. I don't know. I may go a different way with this. You know, if she does re-enter, obviously that's reassessment. What's the same? What has changed? And what, based on that, what interventions might be possible at that time? The other thing, though, that struck me as we were having this conversation, and particularly with the doctor, was, you know, how many points of intervention were attempted here, both in the office as well as the hospital, and the number of individuals that interfaced with her in an attempt to provide that engagement into treatment. And I know we talk about the multidisciplinary team effort as it relates to improving the patient care. I think this is a great collaborative model also for sometimes how we have to lean on one another. Sometimes because of the nature of this, of the relationship with our patients, we end up working a lot harder than they are in the very beginning because that's the disease, but that takes a toll over time. And I just think that having the ability to talk to one another and to run this by one another and to ask those questions about, am I okay? Did I do okay? And ask those really, really difficult questions, I just think is really important. And I think that's one of the pieces that's really important in any collaboration like we see here at Project Echo.
Thanks, Bill. Anybody else have any suggestions? Courtney, you were talking a little bit about the CRS. I'm going to count that as a suggestion. Do you want to elaborate on that or think about any of the other, you know, what specifically from the county perspective?
Yeah, I was just going to say that I can actually send out the referral forms for both places so that you know how to contact them.
Great.
Is that, Courtney, is that a county, a referral to the county for a CRS to come out?
No, you would send the referrals directly to either Confront or Pyramid, and then they'll have their CRS outreach work to them. So you have the person's contact information, and they can contact them.
Does everyone know what a CRS is?
A certified recovery specialist, right?
Yes.
Service support.
They don't know.
Mm-hmm. Thanks, Sarah. That's right.
And it's somebody that's in recovery that will reach out to them.
But is that a county? Does the county contract with Confront and Pyramid to do like how?
Yes, I mean a lot of insurances will cover it if they're in treatment. So the county will actually fund it if they are not in treatment yet.
Okay.
And Courtney's coming from Lehigh County. Northampton County has some resources as well, but it's a somewhat different referral process, right? If they don't have insurance. Schuylkill County, Bill, what are the CRS resources? I know you've got a munch going on there, but what are the CRS resources in Schuylkill County?
CRS resources in Schuylkill County, I know Cadenzia Outpatient Treatment Program has a CRS, and we sometimes utilize that CRS for our patients as well. And also Clinical Outcomes Group also has a CRS or several CRSs as part of their Center of Excellence.
Mm-hmm. Great.
Is the client we're talking about a Lehigh County resident?
Yes.
Okay.
All right. Thank you so much. Let's go in the room. Jess, what kind of suggestions do you have?
I think that once she does, so if she does return to care, or if we find her, or anything like that, I think encouraging her to stay engaged with someone like a CRS or some sort of case management, because it sounds like if she does return to recovery, then she will, and it looks like the sister is a close tie to her, so she may lose that relationship once again. So I think she's going to need case management or a CRS or someone to be able to lean on and to go to if she needs anything. So really encouraging her to have that engagement and find like a healthy relationship during her sobriety.
So focusing on support and relationships.
Can I ask a question out of naivete?
Yes.
Is there any way to discharge semi-directly to like an outpatient? And for example, like I realize it was the weekend, so it's really difficult for you to kind of coordinate that. But is there a way to kind of ensure that she can go, okay, you're leaving right now, let's get you right to the clinic, instead of having your wibbly wobbly in between time?
Yeah, easier said than done. I mean, that in an ideal world, yes. So when Abby, you were asked about when Tox sees the patient. So if Tox sees a patient, it's for MAT. So we'll start the patient do the induction, and then we always involve Paige. She's both kind of a social worker, case manager, and happens to also be trained as a CRS. She's in recovery. Now, she was not involved in this individual's situation. It's probably because she wasn't available. So if it's either the weekend, we've tried to clone Paige, but it hasn't worked yet. So she's there during the week, Monday through Friday, unless she's on PTO. So in an ideal world, Paige sees all patients. Paige really, at this point, she has sort of a dual role that she has that CRS conversation at the bedside. That's just, I've been there. That's just being present for the patient, doing some motivational interviewing. She then steps away and then ends up being a sort of a case manager too, because she links the patient to the program. When Paige isn't there, we do that referral process, so that usually comes to me, and then I coordinate with the program director. Even on a good day, it's a couple days before the patient can get in to Pyramid. We can make an appointment, but it's just they have limited resources in terms of assessors, and our ideal situation was get them right over there. The county funds a bus pass to get them over there. The county funds the bridge script to carry them through that process. Paige keeps in touch with them. Even if she's on PTO that day, we reach out to Paige so she can reach out to them after they leave the hospital. So she tries to help with that bridge process. But it's, I wish that was the case. It's not, it hasn't been the way it works out, but that would be ideal. Although even in case, situations like this, sometimes the patient or the client just isn't ready for that. And I find when I'm having that conversation where I feel like it's not working well, it's almost always because I need help with the CRS. So keep coming back to the CRS. And in those situations, that's why we always call Paige. And sometimes we say, we really need you here right now. We have a patient who's trying to leave. And she comes over as soon as she can. And it's really and so in the cases where Paige isn't available, it's a reminder. So what would a CRS do right now? And outside of the piece where a CRS is in recovery and can so really look the patient in the eye and say, I've been here, I really feel what you're going through and that there is hope. I think that another big piece of that is that step back, which is hard to do. We've talked about in prior ECHO sessions, but it's time to, as we continue to try to sort of coordinate and do, it's not necessarily the moment for like bus passes and bridge scripts and appointments, because none of that's getting through. It's like it's time to take a step back. And it's hard for nurses to do that. It's hard for docs to do that. It's hard for talks to do, like all of us kind of try to our fixers. So that's when sometimes I feel like we need to step away. And ideally when Paige is available, she steps in not as a case manager, not as a social worker, but as a CRS. And I've seen her have that conversation. It's incredible. It's such a reminder to myself, like, look at that conversation. That is unreal. It really would require an immense kind of frame shift in the way I, as a provider, talk to the patient. It's a good reminder to try to get, if you ever get to witness that. And I'm not saying that would have necessarily for sure solved this situation, but yeah, I think there probably would have, if available, that would have been super, super helpful. I wish we had like telemedicine CRSs. It's like an iPad where you could just, you know, in 5 minutes, like we get on with our interpreters.
There's an app.
Like, there is, that get on the app and talk to a CRS just for that moment where it's like, I'm gonna step out because I'm really messing up, or I don't know, yeah, I need a, you know, and it's just, yeah, it's a resource that we could use more of. I love this Courtney's, I don't know about that process, so I feel like that's something we could do, although it doesn't sound immediate necessarily. We're budgeting for a CRS if the network, if it makes it through budget season, we'll see. So, yeah.
That's our theme.
It's our theme for the day, yeah.
They're so powerful.
Yes.
And community health workers, CRS, CPS for our mental health.
Yeah.
Powerful.
Absolutely. We definitely need more pages. That would have been ideal. A host is available in the hospitals for that. Most of the host evaluators are professionals in the drug and alcohol field, which also comes from a different perspective than the medical or tox or the nurses or anybody else in that room. So I think that would have been basically like a secondary option. If the CRS is not available, getting someone in there from host to evaluate. She sounds like an ideal referral for long-term inpatient, especially with, you know, all of the situations going on, not having the support, not living with the girlfriend anymore, not having full custody of her kids, because that's usually what gets in the way for our women to access inpatient treatment. So all of those being basically out of the way, you can say if she was willing to enter inpatient, she would be an ideal case, because that will get her hopefully through the continuum, starting in long-term and stepping down, hopefully to a halfway house, and getting her the support, getting her a job, getting her training, in just getting her on her feet and learning her own way, her own recovery, providing Narcan for those day and a half gap, which are huge when it comes to opiate use disorder. You know, leaving on a Saturday and not having an appointment until Monday afternoon, that's an entire, 48 hours of possible overdose active use, who knows. Hearing her story, I wouldn't be surprised if she came back through your doors at all. There was a connection with you anyway, the time that she was in the hospital. The fact that she returned to her follow-up appointment, that's huge. Right now, she's just probably pissed off at you, and that's okay. But hopefully that's all that it is. Well, you know what I mean? Like, hopefully she's alive and pissed, and that's fine. And she comes back in a week. And when you get to see her again, it's addressing the harmful behavior. She may be prostituting herself. That's really prevalent. With her use disorder, with her history, with the lack of support. So she may actually be in jail right now. A lot of times when their cell phones are disconnected and they're not dealers, it's not because they got a new phone, but because they're in treatment or jail. So that may be what's going on, who knows. There is that part of the Allentown Police Department that does the well check. I don't know whether that's something that you could even do anymore. I don't know how many days after seeing her, if it could just be like a concern, hey, knock on her door, or, go to her parents' house and see if they've heard from her, because you're concerned about her well-being. They do have representatives. They have at least one person that is trained. She is a mental health counselor, but does do the visits for drug and alcohol and substance use. So that would be something that could be done if the hospital allows, because again, I don't know what the protocol will be for you guys to use community resources such as that one. So that would be the suggestions of things that maybe could have been a little bit differently while she was there. Again, host, CRS, absolutely, but if we can, second, host, getting her Narcan, getting her trained on Narcan, talking about it and explaining the importance, and her hopefully walking out whichever way she is able to leave the hospital with it, and getting it in her hands, or giving her the script. She was going to go pick up that Suboxone for those couple of days anyhow. So if that was the case, then for her to go to the pharmacy, pick it up. And for you, I think, I want to thank you for presenting her. It just makes me happy. Being in the field all these years and working with different doctors in different ways, and many are just kind of like, okay, well, I did my job. And we're like, wait, but this is still a person. And it's she's at high risk and there's a lot going on. And it's nice to know that, you made a connection with her too, as much as she did with you. And you're asking for help in case she does walk through again, or if you were to have someone similar to her, that you know which way to proceed for next time. So good job.
I actually did send her a Narcan script after she screamed at me in the office. I sent it to the pharmacy. I don't know if she ever picked it up or not, but I figured that was the least that I could do.
Yeah. That's great.
Thank you so much for sharing. This is, it's really valuable to hear as a student things in action and to be able to see that. So thank you very much.
Lynn, I told you it was going to be a great case, so more on the thank yous. I think, the drag of going last is that you've heard lots of wisdom from wonderful people. But I'm going to go backwards through a couple of things. I think one thing that's interesting that I'm struggling with also is how do you unpack the stigma around Suboxone? We have a set of conflicting ideas that are alive and well in our communities about what does recovery mean, and what does addiction mean, and what does treatment look like. And we know that in this case, medically speaking, Suboxone's the right answer. You check that box and you pass your exam. But how do you help someone who doesn't agree with that idea explore their options? And that's a tough one. We'll probably spend more time at future echoes trying to talk about that. We know that we can talk about numbers and statistics and figures. We know we can talk about pain management. I heard some really wonderful, funny approaches to this at the ASAM conference. One of my favorite educators out there, Corey Waller, was talking about how he's got all his patients trained on neurobiology, so he can say, yeah, that was your lateral habenula there that was just telling you what to do without, so that's great, but you didn't have a chance to do that with her. But I think, whatever we can do to help educate communities, one patient at a time, one family at a time, one treatment program at a time, about what do we know now about addiction that we didn't know 10 years ago, that helps us understand that Suboxone's a really effective life-saving treatment. And I've got all the words, and sometimes the words aren't enough because people's support community are giving them a different message or something like that. What we have been saying, and you and I talked about this a little bit, if somebody is really set against Suboxone and feel like it's just extending their addiction, the chance that that they'll do well with it is not very high. And really at that point, the best option for them is to talk about inpatient. We had at NHCLV been under a misapprehension as the world of inpatient detox shifted under our feet. We thought we could send people to detox and they could get detoxed off of the opioids that they were using, and then either could get a Vivitrol right away, or maybe we go meet them and give them a shot, or what, how do you do the coordination with as little time in between as possible? But now most of the insurances are only paying for a 5-day detox, and they're doing a rapid Subutex taper. So they come out of detox, they're not ready for a Vivitrol shot. So that isn't effective. What we need to be telling people if we're doing that is, if you want to go to Vivitrol, that's going to be a great idea. For her, maybe not because of the pain issues, but that's more to talk about. That they need to engage in get themselves admitted to a 28-day program. They can leave AMA, but they need to stay there long enough to be able to get a Vivitrol shot. So that's one alternate approach. I think I wouldn't have been using that in the hospital because it would have seemed like the right idea to give her Suboxone to manage the pain as well as the substance use disorder. Another word about coordination when it goes well. What we've been able to do at NHCLV a couple of times, particularly with people coming out of jail or coming out of inpatient treatment, not as much as coming out of the hospital. That's been a little trickier because we don't hear about it until later. But we have been able to have people get in a cab and come right to NHCLV to get a Vivitrol injection or to get a kind of reassessment. Sometimes our case managers and CRSs are perfect for this, can go to a AA or an NA meeting with people. And that can really help, having some company, somebody that they've met, if you can do the warm handoff, so that they've met this person and say, this person, you know, I'll go with you to your next meeting. Seems like people are more often going to go with that kind of thing. When all else fails, the stepping back and the harm reduction. I think sometimes the Narcan prescription is absolutely the right thing to do. It definitely makes me feel better, which is good. I feel like I've done something. Talking to people about clean injection practices, having some of Yamalisa's clean kit, right? Or at least just giving them a little something about how to do this, making sure that they've been screened for infections and all that kind of thing. I don't know, and this is a question for Jillian, is there a way for us, if someone's leaving inpatient, to have the pharmacy bring them Narcan to bring home?
If they're admitted, so probably you could, I think you could, probably the best way to do it would be to call Health Spectrum and to say, I'm calling in, a Narcan script can be brought to the bedside. Because when we were building this endocarditis protocol for patients, and that was part of the discussion, was bringing meds to the bedside for their transfer. So I think it can be done. I think it probably just requires some coordination. And a lot of, lately I've found some of the Medicaid, a lot of the Medicaid, like Caritas, covers it with no copay or anything. So if we'll call in a bridge script and a Narcan script, and the patient just goes down and picks it up. But I don't see a reason why you couldn't ask them to I don't think they can tube this box. I can't remember. Maybe tube controlled. I can't remember. Anyway, but they could be brought up to bedside.
That's cool.
I believe so. I think it would just require a phone call directly to the pharmacist to ask about it.
And do you think is there any training at discharge, or anybody, I don't know whether Paige does this or whether other people do Narcan training for families while people are admitted?
So Paige can do that. We can do that. We have kind of off the record Narcan that is Fleming Foundation funded that we can do. We can bring the that's officially not. Or we can write a script, and if we're writing a script, then we do teaching at the bedside. I have a visual from Adapt Pharma that I use. But we're actually, Paige and I are working with DOE to make our own version of it, so it doesn't have to be from a pharmaceutical company. So Adapt is pretty harmless. They do a lot of, education outreach and
real information.
Yeah, but it's just an image of, to show people how to use the Narcan. There's also we used to do a video at the bedside, but then they started charging for it. It's getting a lot of now. So now I just play the Adapt Pharma little video. can certainly.
There's a couple that are on YouTube that I have shown people.
Yeah, they're all fine. I mean, they're all nice and simple. And, yeah, so we can do that. I think we should be doing it more. But as long as talk is involved, and usually it's I don't know what the other attendings do, but the fellow is consistent and he's comfortable doing that. It's great. Yeah.
So Lynn, one thing that you and I might be able to commit to each other is maybe we can go talk to the inpatient team as a whole and see if we can develop some discharge ideas for people who are leaving the hospital with substance use disorder for harm reduction. Yeah, great.
A quick question.
And we're actually out of time, so I know people need to go, but go ahead with it.
Just for like, are you able to, because of course in my head I'm like, we need to find her, right? So are you able to run the, I don't know, PDMP just to see when and where was the last time she filled anything?
I didn't write it, so I'm not sure if I can track her through my PDMP, but I probably could still look her up. Right?
You can still look her up. Yeah, you can look up anybody.
Yeah. Just to give you, like, I don't know, an inkling of where, you know, there's,
All right, everybody, this is a great case, wonderful. Bring more cases. We'll see you on the second Tuesday of May. Please fill out a survey. The link
in the chat.
The link is in the chat. The link is in your reminder. The link is everywhere you could possibly want to see it. Thank you. See you in a couple of weeks.
Thank you.
Yeah. Oh, good. Like an overview of it.
That's great. Oh, perfect. Good.
If you need a